Lo primero, los conflictos de interés. Solamente he recibido honorarios por panel de expertos de la compañía VIV. I only received honoraria for advisory panel from VIV. The objectives are going to be to present the benefits of the Cascade of Care and its use in making policies, presenting the data available in Puerto Rico in the Cascade of Care for HIV, and presenting the data and the limitations for establishing a Cascade of Care in Hepatitis C. The Cascade of Care is a very important strategy for monitoring the global response for the epidemics of HIV and HCV. The metrics used in the preparation of the Cascade of Care are a form of using simple metrics that have made available for stakeholders and people who are not in the scientific community to understand the progress made in the goal of eliminating both HIV and HCV, and made the adjustments necessary in order to see if we need to monitor or to change what we're doing in the progress of elimination of both conditions. The National Strategy for HIV and AIDS and the Initiative of Treatment as Prevention has been very interesting for the stakeholders and policymakers in the scientific community and the academia. The Cascade of Care is now the element that is sentinel that permits making estimates of the prevalence for different stages of the continuum of care and calculate for policy intention of the status of seropositivity, the people who don't know their seropositive state, the engagement to care, the ones that are miss or abandon care, and the ones that obtain suppression. Initially, it was presented in Washington, D.C., and we know the politicians are there, so they usually don't understand this type of thing, and Cascade of Care is a visual representation that makes us, even if we're not in the scientific community, understand what has been done and how it's working. So it became very modern. It was the thing, and made possible to make some estimates of the prevalence of cases and the next steps in order to get virus suppression. And we both know that the Initiative of Treatment as Prevention, in the goal of doing that, is to decrease the community's viral load in order to prevent transmission. And that is a way of getting to the cure by other means. If people cannot transmit the disease, a disease that is transmissible, if you don't have an animal vector in between, you're going to eradicate the disease. So that's the 90-90-90 thing. And we are starting treatment, or the recommendations of starting treatment as soon as possible goes to this prevention of and decrease of community viral load, and the clinical benefit that has been shown in terms of other non-AIDS related conditions that are more severe in patients who have HIV, as we have seen with the aging and the HCV co-infection. So the national estimates in the United States have shown that 50% of the people infected with HIV do not know their status. And 50% of the people who are infected are not engaged in care. The initial data showed that only 19% was suppressed, and a recent actualization of those numbers say that only 25% of the people infected nationally are virologically suppressed. So 20% of that 50% does not know that their serostatus, and more than 50 are not under medical care. In Puerto Rico, we know by the works of our surveillance system that 10% of the people infected do not know their serious status, that they have HIV, and that daily we have 2 new cases of HIV. You have seen, because everybody has presented this slide, so I do it also. And we have been seeing, and the ones that we have been here before Menudo, we know what happens in the 80s and the beginning of the 90s in terms of patients presenting with AIDS. Now we have an increase in patients who have HIV, and we have decreasing presentations of AIDS. Many of these numbers have to do with the age of the people when they're being diagnosed. We know that people are being diagnosed younger with new infections, or if the person is older, tends to be diagnosed with more severe disease, which means that they have been infected for a while. So we have 49,675 cases of HIV in Puerto Rico from 1980 to 2019. We have had 29,205 dead people, 18,473. These numbers are up to August 2019. Are still living in Puerto Rico with a diagnosis of HIV, and 678 children are living with a diagnosis of HIV. We are placed in the United States with the 12th place in terms of the rate of diagnosis of HIV in adults and adolescents over 13. We have the 6th place in terms of prevalence, and that is good. That means that our patients are surviving longer. So that's why our prevalence is higher than the amount of patients in terms of the 100,000 population. And we have a 10th place in terms of the incidence of patients with HIV. With the other, we can consider ourselves metropolis, because most of the places that have numbers accompany us in the other 9 spaces are places that have a significant metropolis. So you won't see that in North Dakota or Kentucky or Wyoming. You're going to see Los Angeles, New York, Florida, Texas. Now the mode of transmission has been changing through the time, and that also has been said by many of the presenters. And the important thing is that we are seeing that men who are having sex with men are increasing significantly in terms of incidence. And besides that, it's very young men who are having sex with men. They're usually below 24 years of age. In 2018, we had 436 new cases of HIV. That would bring us to a rate of 13.6 for every 100,000 persons living in Puerto Rico. The diagnosis is 4.4 times more in men than in women. Sex between men who have sex with other men without protection was the principal mode of transmission, with a 50%, followed by heterosexual contact without protection, the 30%. And daily, as I said before, we have 2 new cases of HIV. The prevalence is 576 people living with AIDS for every 100,000. The prevalence is 2.5 times higher in men than in women. The metropolitan area is 1.6 more higher, the prevalence, than in the rest of Puerto Rico, and we're going to see that in another slide. And 10% does not know that they have a diagnosis of HIV. Now, the continuum of care in Puerto Rico, we have here, using the 100 of the population of persons living with AIDS, close to 18,000. From those, we have 12,131, which is a 68.9% on care, which is a significantly good number. Of those, most of them 66 is going to be retaining care. Of them, 62.8 are in antiretroviral therapy, and of those, 55%, which represents 88% of the people living with AIDS on care taking antiretrovirals, are suppressed. Now, those numbers are much better than the national numbers in the United States. I think that the success of this, of course, there's a lot to be done yet, but the success of this model has to do with the one-stop shopping model that we use in most of our clinics and services, where the patient receives all their care in the same place. They get the labs, they get follow-up, they get engagement for care paid for by Ryan White. So in terms of controlling the transmission of HIV in America, which is the national goals of achieving a goal of reducing the new infections by 75% and a reduction of new infections by 90%, we're going to need to make diagnosis available, which means that we should be able to test people in more places than once a year in the National Day of doing the AIDS test. Primary care physicians should be comfortable in making and offering the test to the people that they are caring for, engaging the patients to treatment, which shouldn't be a problem since we have federal funding with Ryan White in order to treat the patients, offering protection to the people who are not infected. I am a little bit biased against PrEP with what is available today. So, as Dr. Rodríguez said, some physicians are a problem and a barrier for the offer of PrEPs. I'm one of those. And we can discuss that between us. And investigation, identification, and the follow-up of outbreaks, regional outbreaks that may happen in some moment. If we are proactive, we can do that. Now, for HIV, we have a lot of resources. You're going to see the surprise for the Cascade of Care of Hepatitis, that there is no Cascade of Care. So we'll see that a little bit later. So when you have resources to take care of the patient of a condition, it doesn't matter if it's HIV or if it's asthma, you will be able to get some favorable numbers and responses. We will have, and we do have, pockets of problems of access to adequate treatment. And we have talked here extensively about incarceration. Now, the people who are in the correctional system, even for HIV, they have challenges in terms of acquiring appropriate medication. For example, in terms of treatment, they only treat with a tripla. Now, if you have a patient today that you want to treat, you would not think of that medication to be the first medication that you're going to offer the patient for a lot of reasons, but that's what they have access to. And that's the reality. The correctional system runs in a different way, and there are political reasons as well as budget reasons for them to do what they're doing. It's wrong, but that's what's happening. For example, the numbers for hepatitis in the correctional system, the last figure that they have is 3,968, I think was the number that Dr. Cecilia Navarro told me. The last time they tested, they're not testing for hepatitis C now. And that number represents antibodies against hepatitis C. They're not confirmed. Of course, they're not in care, and they're not giving medication. One of the reasons that they're not testing anymore, they used to test the inmates when they got to the prison and when they went out. Now they're not doing it, and the reason is simple. There isn't supposed to be drugs in the correctional system. So if you get a person that has hepatitis C negative when they're in the intake and they come out with hepatitis C, they can sue the prison system because he's not supposed to get infected there because there is no drug in there. So they decided not to do testing, and they're not doing it. So the patient comes out from the prison without knowing. Usually they get into sexual activities, they go and get tattoos done, they are using drugs inside. So the place that probably has the highest incidence of new cases of hepatitis C and has the highest prevalence is going to be the prison. Now, in terms of the cascade of care of hepatitis C, it has changed dramatically with the advancement of the new highly effective DAAs. There is an estimate that at 2010, only 4% of the people who had HCV had achieved a cure. When we talk about viral infections, usually cure is not the word that we use sustained viral response, because the cure of a viral infection is very difficult to determine, because many different things that have to do with the way the virus works. So the prevalence of HCV in the United States, it's being calculated that is 4.5 million. And from those, 80% are people who are represented in the enhanced study. That's why the CDC made this recommendation of testing the baby boomers, because that study showed that the people who participated in the enhanced had surprisingly a high prevalence of hepatitis C. Of this group, only 38% know that they have FC, and even less have been achieved to treatment. Even though we have these new highly effective therapies, and companies have decreased the amount of money that these medications cost, which initially was absurd. It's still absurd, but it's less absurd. By 2013, there is an estimate that only 68% of the infected will know about their condition, and 49% would have received treatment. Now, you all know and you heard, that's why I had a question to yesterday, that WHO has a very ambitious goal of having hepatitis C cured by 2050 and to have a significant reduction by 2030. And estimates suggest that probably that's not going to happen. There is a significant variation in terms of the access to testing and treatment for the people who have Medicare having the highest access of a 68%, and the people who are confined to jail with less than 1%. And the things that we have to know when we're going to be making a policy regarding hepatitis C, we need to know the demographics, the disease progression, the therapeutic advances, screening policies, which is what I was saying yesterday, that the policy is wrong. If we want to prevent a disease that is transmitted virally, that is not by a vector, but it's from patient to patient, you need to test everybody, but you have to concentrate in the highest spreaders, because the baby boomers are not spreading infection. They may be the highest prevalence, but they're not the ones that are behind the incidence. The ones that are behind the incidence are the ones that are in the opioid crisis, the ones that are in jail, the ones that go to the methadone clinics, the homeless, the many people who have mental issues. Treatment capacity, healthcare accessibility, and insurance coverage. Now, why we can't do a cascade of care in Puerto Rico? We don't know the seroprevalence of HCV at this moment in Puerto Rico. We don't have a study, we don't have those numbers. We don't know the numbers on the different pockets of care. We're not testing in jail. We're not testing in methadone clinics. We're not doing seroprevalence studies. People are getting care by private insurance sporadically. Not every insurance company covers the medications because they're expensive. They're being more lenient now. Medicaid, which is the primary health insurance in Puerto Rico, and this is supposed to be happening just now. We were supposed to start treating everybody from July 1st. That's what I was told personally from the acting director now of ACES, which at that time was the sub-director, but then S happened, and the S hit the fan, and now she's the director. Anyway, they calculate that they have 14,000 people to care for with hepatitis C in the health insurance in Puerto Rico. I don't know where she got that number. She told me it was 14,000, I have to believe her, but anyway, right now they're only approving treatment for transplant patients who are in access or have significant risk of losing an organ. That letter is supposed to change at some point soon, but that is the letter, the normative letter that came out from ACES several months ago, and they are also only approving one medication, which I'm not going to say which one it is, but you only have access to one medication. So not everybody can take that medication. So anyway, let's look at the Cascade of Care in the United States from around 4.5 million. And this slide shows what was happening in 2010, what is happening in 2018, and what they expect to happen in 2030. And as you see, there's the people who have HCV. The people who are aware are significantly less. The people who have started treatment are very few, and the people who get cured was a very low number because we were talking about treating with interferon, and now with the new medications, the response is significantly good. But still, from the total picture, it is very depressing. Now this is the Cascade of Care, not the projected, but what happened in 2018. From 2,400,000 plus people who were viremic, 36% were aware that they had disease. Among the viremics, they were engaged in treatment 11%, and that same number was cured. Now, if we take that same first slide and we take the subpopulation of the non-HANES patients, which are the people who are in jail, the people who are disadvantaged, the people who are in mental institutions, you can see the last column. The amount of people that are going to be on treatment or are going to be cured is less than 1%. That's the number at now, and that's the number projected for 2030. Now, those are the people that are transmitting actively the disease. The amount of outbreaks that have been documented in the press in the United States are associated to use of IV drug in the United States, and it's probably what is happening in Puerto Rico. There was a study done, and I don't remember who did this, on a group of homeless people in Puerto Rico that were HCV negative. They did the testing initially, and they did the test at 1 year. 85% of those people had converted to HCV positive in 1 year. So that's the magnitude of the problem in these high spreaders. Now, this is what we have to do, how do you call it, a cascade of care. The only numbers that we have are the ones that AIDS surveillance had. And they receive because now it's supposed to be reportable and everybody's supposed to report their positive cases. But the reality is that they are not reporting, and we only have 1,200 plus cases, of which we don't know which are viremic, which are not viremic. It's just the laboratory reporting to the AIDS surveillance system. Now the problem is the AIDS surveillance system is a federally funded program. They are not supposed to be engaged in doing anything that is not HIV related, because that is misuse of federal funding and it can be penalized. So they're receiving the information, they're entering the numbers, but that's all that is being done in terms of the government surveillance of HCV. We don't know what this means. This is not a numerator, this is not a denominator. With this you cannot do anything. And that is what we have. So the surprise is that there is no cascade of care. On the other hand, and that's what I'm going to finish my presentation with, this can be cured very successfully. In my clinic, and the 8 clinics had treatment available, but we started a pilot study for HCV, first with monotherapy, then when it was approved to use ADAP money to treat the HCV and HIV co-infected patients, we were able to treat a lot more. So with initial money, we started a treatment of mono-infected patients with HCV, and in 1 year we were able to treat 38 patients. Of those, they were men and women. Most of them were IV drug users or had achieved the HCV with IV drug. We had a representation of genotype 1, most of the patients, but also 2, 3, and 4. And all the patients suppressed and all the patients were cured. Ahora sí que me salvé. Technologically challenged, you know. Dale. Okay. This shows the rest of the study. We were able to treat 397 patients. There were all the genotypes. From this sample, only 12 of the patients were F0 to F2. The rest of the patients were all F3 and F4. We treated the sickest patients. Now the end result was that 100% of them in intent to treat analysis were cured, and 98% in intent to treat, and 100% in treated were cured. We used all the medications that were available for HIV patients approved by FDA, because until they were approved by FDA, we couldn't treat them with federal money. But the fact that we had ADAP numbers, ADAP funding was what made possible that we used them. Now we had a very active program. We didn't have complications. We were very fortunate that we didn't have any patient who went into liver failure, because many of our patients were very sick. The result is that patients up to now have stayed suppressed. We need to retest them and see if many or any patient has been reinfected, which is suspected to happen, you know. But the message with this is that this is something that can be achieved. The problem is that we don't have the money that we have for HIV, we don't have it for hepatitis C. We need a significantly funded surveillance system to know the magnitude of the problem, which we know is probably significantly higher than in the United States. We need DOT, direct observed therapy, for patients who are in certain challenging settings, which would be like methadone clinics, because these are very expensive drugs. And if you can sell one of these pill bottles you can get quite a penny. We're talking 30,000 per bottle. So we need to make sure that the patients are taking the medication by directly observed therapy. We need to fund and man the surveillance system that already exists. We have a system of partner notification and searching for patients for HIV and for STDs. We can use that model to take care of hepatitis C. And it's going to be less expensive than a transplant. So we should be doing it. But I don't think that in the future there is the amount of money needed for this eradication program, which should be successful since we are on an island 100 by 35, surrounded by water, many water. So anyway.
Huge water.
Yeah, beautiful water. Anyway, if we're not sold to Denmark, we should be able to get, try to get some funding, and we could, with the adequate interest from pharma, government, and the federal government, to make a pilot study of eradication in Puerto Rico, and I think it would be successful. Anyway, I would like to thank Sandra Miranda, which has been the person who gave me all these slides, and she gave it to also all the other presenters, because her slides have been the most popular in this conference. And also acknowledge in the bibliography that I use the information on changing Cascade of Hepatitis C and the Consensus Hepatitis C Cascade of Care presentation in AES in CID. And I'm available for questions or not for questions. And thank you very much.